worsening, numbness, initially to the feet, going to the waist, and now involving both hands. And that's the MRI. It's a brain and a cervical spine MRI, and the brain images.
Okay, sir.
You have to pick up some speed so that I can show you more cases.
Okay, sir. So I've been provided with axial sections, flare images of this patient who is having mobility issues progressively increasing from feet to the trunk region.
Yeah.
Uh, on these
Okay.
flare images, I don't see. So if you can change the window a bit, so that
Yeah, I can change the window. Can you? Is it okay with you?
yeah, yeah, yeah. So here,
Okay. Can you see anything?
no, I can't see much.
Okay. So if it is normal, then this is normal. So that you
Yeah,
don't see anything.
yeah.
It is a brain and a cervical spine study. So as I said to you, do you want to see anything else in the brain before I show you the?
Since I've already seen the flare images, I like to just take a look at the diffusion weighted images if they're
You want
there.
to see the diffusion weighted image? Okay. Here is the diffusion weighted image.
Yeah, they also don't see show any obvious acute restriction focus. So then I'd like to proceed with the cervical cord MR.
Okay. So here comes the cervical. So this is your T2. I'm going to change the window for you.
Okay, so I've been provided with T2 sagittal sections of the cervical spine, this patient, and I can see some hyperintensity, long segment T2 hyperintensity spanning the cervical-dorsal cord, in fact, from the level of C2 vertebra till the upper dorsal levels. And with this, I like to correlate this with the axial T2 sections as well. Um,
Okay. So here comes the axial T2 section. I will mag it
yeah,
up for you.
okay, sir. So here again, I can see that the hyperintensity which I saw on the sagittal sections are also evident on the transverse sections also.
Yeah.
And it's mainly involving the posterior portion of the cord in the affected areas. So since
So
it's a long, furthermore, I would like to see the diffusion weighted images of the cervical cord as well if they're there.
no, there is no diffusion weighted image on the. What do you want to see in the diffusion? What is the purpose of you asking for a
Any
diffusion?
any just to rule out any ischemia.
Remember, the cervical cord is very heavily vascularized, both the vertebral artery supply and
Okay,
ischemia of the cervical cord is not a common phenomenon, it's a rare phenomenon.
okay, sir.
Okay.
Then stud images if they're there, but although I have
No, this is what you have. This is what you have.
okay.
So, what do you think now at this stage?
So at this with this long segment involvement, I believe that this could be a case of myelitis,
Okay.
uh, um, or could be due to subacute combined degeneration of the cord because these mainly involve the posterior portion of the cord. And I believe that MS is unlikely because the brain is spared and it's a long segment involvement of the cord. So I believe these two possibilities as differentials in this case, but I would like to correlate with the clinical overall clinical picture, the biochemical parameters to come to
Okay. Okay.
final
So,
diagnosis.
for
Clinical presentation as
the
well.
audience, let me sum it up. Um, the brain sequences, flare and diffusion, we saw they were okay. There were no problems with it. Then we went to the cervical spine sequence and we saw, and this is the signal change in the cord, if you see, I've changed the window, and you can see there is signal change in the cord. You can see here it's in the posterior half of the cord, and if you can see here on the axial, as I scroll down, you can see the signal change is in the posterior columns, the dorsal columns, and this is a very long segment involvement involving right from the cervical down into the dorsal. So much of long segment is not usually that of transverse myelitis or ischemia, especially the dorsal side. The dorsal column involvement is that of a B12 deficiency, subacute degeneration of the cord, and this is a classical picture. It's a diagnostic picture. You don't need post contrast. You only need to get a B12 check. And you, if if you look at the follow-ups, you will see that the follow-up, this has become even more prominent, because initially it was not treated, and when it got treated, you can see it is more going down to the thoracic spine. So well done. That is a good one. Excellent. You did a good job. So
Thank you, sir.
you wrapped it up very well. You were doing good on this. Okay, so let's do you another case before candidate number two. Please keep an eye on the timings, that when his 40 minutes are done, then please let me know. We have to give him some margin because we started a bit late, so we have to give him a bit of margin. Okay, so this is a patient who came to us with unwitnessed fall, loss of consciousness, bilateral, I'm reading exact history, bilateral orbital bruising, nasal query fracture, hypertensive, low heart rate, rule out intracranial complications. So I'm going to
Okay,
start from the top.
okay, sir. So I've been provided with non-contrast CT sections, axial sections of this patient, and I can see that there are prominent ventricular system as well as the sulci, and besides that, I can see that there is pronounced hypodensity of the periventricular white matter as well as the white matter in the centrum semiovale, and some besides hypodensity was also seen along the capsule region bilaterally.
Okay, okay,
So, and sir, if you can come down.
okay, I can,
Yeah,
yeah, good. You have
in the
started to
basal
look at foramen magnum.
sections, yeah, in the basal sections, I don't see any significant finding in the brainstem area and in the
Okay,
orbits. So,
okay, carry
yeah,
on,
but
yeah.
there's definitely pronounced hypodensity in the white matter area regions, yeah, in this patient.
Okay, so how would you sum this up?
Um, So this finding could be incidental in nature and not related to the trauma which the patient has sustained. So I believe that this could be related to the chronic hypertensive status of the patient.
Okay,
And I would like to further negotiate this with the MR scan if they're
okay, what do
there.
you want to see in the MR?
I'd like to look at the flare images, T2 and flare images.
Okay, so so for the audience, let me sum up this case on your behalf. You see Physicus 3 scale, confluent white matter, small vessel ischemic changes. You see some ischemic changes in the basal ganglia. You see some ischemic changes in the thalami, maybe some small ischemic changes in the pontine region with generalized involutional changes. Very, very important in this case is there are, which examiner wants to hear is, are there any brain contusions? That's number one. Or is there any intraventricular hemorrhage? Is there interpeduncular cistern hemorrhage? Is there
No,
any
no.
hemorrhage along the foramen magnum layered? So these are the things examiner wants to hear. And is there any traumatic subarachnoid hemorrhage or subtle subdural or extradural hemorrhages? Those are the things that examiner wants to hear, which were important. The other thing which I want to classification. So this tells the examiner that you have seen the high density, but you have ruled it out that this is not real. It is because of the calcification. Now, the very important thing which I expected you to do, which you did not ask, so I did not give you, was you did not ask me to look at show you the bone window.
On
So
windows.
now I'm going to show you the bone window. So have a look at the bone window. Very, very important in exam to show the bone window, that is, or at least ask the examiner, I want to see the bone window, especially this is a trauma situation. Okay,
Okay,
over to
so
you. Here you go.
I'm going through the bone window axial sections of this patient, but I'm going from the vertex downwards, and till now I've not been able to see any fractures. Uh,
Yeah, keep going, keep talking.
yeah, I am now looking at the basal sections, and I don't see any obvious fractures till now. Yes,
So coming up now from the
yeah,
bottom, coming up again.
yeah, and again I can't see any obvious fractures. The temporomandibular joints also look normal. The orbital areas also look normal to me. No obvious fractures which I can see.
Now, here is something for the general audience. When you look at the bones in exam, remember you have to keep the examiner engaged. So if I was looking at this CT scan, I would, on way going down, whether I want to see the front or the back, I would say I'm looking at the front of the calvarium, and I'm looking at the frontal bones, and I'm looking at the part of the temporal bones, but at the front of the calvarium. I'm looking at the frontal sinuses. I'm looking at the orbits. They look normal. I'm looking at the sinuses. So you are telling the examiner what you are looking at, because examiner does not know what your heart is thinking, or your brain
Yes.
is kind of thinking how you're going. So then I would say I'm looking at the front, the ethmoid and sphenoid sinuses. So I'm just concentrating in the front half of the calvarium. So I'll
Yes.
say here I can see movement artifact of the nasal bones. I can't figure out there is a fracture or not. I can see there is significant soft tissue swelling. Because of movement artifact, I don't know there is a fracture or not, but I can see there is no blood in the maxillary sinuses. So this comes why, and then I've reached this. Then I say I'm now looking at the mandible, the part of the temporomandibular joints. They look okay. Zygomatic arches are okay. I'm looking at the squamous temporal bone. So you are coming up on the middle part of the brain. So you have seen this, you describe, keep coming, and then I say I'm going down on the occipital part of the calvarium. There is nothing in the occipital bone, nothing in the petrous temporal bone, etc., etc. And then I stop here. What do you see here? What is this? What is this? And which bone it is? So this is the C1 ring. This is the dens, which shows degenerative changes. You saw this patient is an old patient, but this is not normal. There is no suture in the C1 arch. So what is this?
Uh, Fracture
So
of
this is a
the
fracture. So
yes.
is this an acute fracture or a non-acute fracture?
Uh, this seems to be doesn't seem to be acute because there's some sclerosis also which I can see.
Correct. So you say that I can see a fracture, but there is some sclerosis around. So this is does not appear a non-acute fracture. So and then the C2 is unremarkable. However, I don't see the full detail of it. I would want to have the sagittal images if I can have. So then they will show you the sagittal image. So look at this. What does it show?
Um,
Which bone is it?
this is odontoid process.
This is the base of the dens. So you can
Yeah,
see
this
a
is the,
fracture going through and
yeah,
through.
yes, sir.
So you
Yes, sir.
would bones with the CT scan. This is an old patient, and on table you would want to, and getting a CT scan is much easier. So you would
Okay.
want to have a CT look of the cervical spine, and then depending on what you see, you would ask for an MRI because this
Okay.
fracture does not look acute.
Yes.
Yeah. So
Okay, sir.
these are important things. So you go through a system: front of the bones, middle of the bones, back of the bones. You or vice versa, whichever way you want, but do not um, miss the base of the skull because that's where you miss major fractures.
Okay, sir. Thank you.
Yeah. Okay.
Okay, sir.
So
Thank
how
you, sir.
much time are we? Are we 40 minutes done with you, or what is the situation? Okay, candidate number two, are you keeping an eye on things? We started, I can show you one more case, in fact, and then I can move on to candidate number two. Let me show you another case. Okay, so this is a patient which has a clinical history of, let me show you, clinical history of uh, upgoing planters and weakness and eversion of the foot.
Okay, sir. So, so these are T1 and
Yeah,
T2 septal related
yeah,
uh, of this patient. Um, so here I can, on the T1 weighted images, I can see that there is a, so if you can just scroll this.
yeah.
Yeah, I here I can see that there is a small, possibly a small lesion there in the upper portion of the cervical cord at the C3, sorry, C4 vertebral level with a tiny T1 hyperintense focus within it. So I would like to further correlate this with the T2 sagittal weighted images. If
Okay, so here is your T2. I'm going to make this up. Okay, so
So here on these T2 weighted images, I can see that there is some expansion of the cord at this level, and there is a lesion in the cord at this level, which I mentioned on the T1 weighted images, and it's appearing mildly hyperintense in the central portion with surrounding T2 hypointensity. I would like to further see this on the axial images if they are available.
okay, I can show you the axial images. Okay, so which axial image you want to see first?
Um, T1 as well as T2.
T1. Okay, so let me just Okay, so here you are, T1 and T2. So I'm scrolling through. Can you see okay, or should I mag it up more?
Um, no, I can see.
There you go.
Uh, okay. So I can see that the lesion seems to be eccentrically placed
Yeah.
towards the left side on the axial sections on these T1 weighted images, um, and I would like to see this on the T2 weighted images also, if possible. Okay. So again, as we saw on the sagittal weighted images, again it's markedly hypointense with central hyperintensity on the T2 weighted images. I'd like to further see this on the gradient if they are available.
This is the gradient echo T2.
Okay, so it's further. I would like to see the contrast images.
Uh, Contrast images were not considered necessary here.
Okay, so
But yeah, good. But why do you want to give contrast? What is in your mind that you think is necessary?
uh, just to mm, just to further characterize um
Okay.
whether
Here is your
it's
contrast.
required.
Here is your contrast images.
Okay, so on the contrast images, I think there's mild enhancement within the lesion. So the lesion seems to be extra medullary intradural in location to me, seeing the axial images, and seems to be displacing the cord towards the right side. So
Okay, so how would you sum it up? Okay, so far let me sum it up for you. There is
okay, so,
an extramedullary intradural lesion at C4
for
level, um, which shows T1 bright signal, T2 low signal, speckled, faint enhancement, in fact, borderline enhancement, which may or may not be there. But anyway, so w- you have given me the description so far, but you have not given me the differential diagnosis of this lesion.
yeah, um, in the differential diagnosis, this could be this could be a small um, um, this could be a small cavernoma, because there is marked hypointense rim on T2 weighted images, which I can see, and with the which was appeared more pronounced on the gradient. Uh,
So
yes, on the gradient.
how
So,
is a cavernoma be? You have said
extramedullary,
extramedullary intradural. It won't be in the thin air. It
yes.
has to be into a parenchyma.
So, but it doesn't fit into any of the extramedullary intradural tumors as well. So,
Okay, so let me wrap it up for you. Okay,
okay, sir.
so it is a lesion which is low T1, marginal central T1 high signal. It has got a hemosiderin low signal with a bright T2. It has got a bright T2 center with a complete hemosiderin rim. It is occupying the left half of the cervical cord at C4 level. It doesn't show any avid enhancement. Given hemosiderin deposition, central non dark T2 signal, this has got features of a cavernous venous malformation. So this is a cavernous diagnostic cavernous venous malformation imaging. The reason why? Because the chemosiderin rim is complete and there is a central mulberry of bleed that usually cavernomas have. Cavernomas
Yes.
of